Huples cat. Just want to talk about the possible effects from the nCoV 2019 virus on healthcare in Ontario and by extension around the richer parts of the world. The breathing you can hear is Miss Becky. The dog barely alive. She's not doing too badly. We're probably going to take her to the vets to get systemic antibiotics. Again, that's going to be a failure of quarantine, but you know, Kitty's life revolves around the dogs, not so much me. And to be honest with you, it's a risk I'm taking for the dog. If we were in fulminant community outbreak, I have a few antibiotics for pets, and there's a few of them that I might start Becky on at this point in time, because this is not nuclear war, and after 3 to 6 months life is going to be back to normal, so I would actually quite happily use my pet antibiotic store for my pets right now. Okay, so what's going to happen? What's already happened? Well, testing's being sped up, more testing's being done, protocols being put in place, so you can't just transfer patients who from China, you have to actually tag them, check them. So what's being done right now is like they're tracking patients who come from there, they're putting people in quarantine who know they've come from there, but there's general IP&C, infection prevention and control, methods in all hospitals in the richer parts of the world right now anyway to screen for respiratory illness, to screen for normal flu. So they are still in place and they've been beefed up. Now, as I keep telling people, you can't put a box around flu, and if it's in the community and it's infectious and it's asymptomatically infectious, it's going to be everywhere. Now I'm going to whap some slides up for people. I'm not going to speak directly to the slides, it's just more for background so you can actually see where I'm coming from. Right now in Ontario we don't have enough hospitals. For some reason we shut hospitals in the end of the 90s because the government decided that healthcare was too expensive to provide in a human and decent method. But more than that, the psychology of neo-capitalism came in. Now okay, don't get too upset, I am a democratic socialist, but neo-capitalism said that we can make healthcare more efficient, that people, because healthcare, we've spent so much money on it, people don't need to be in hospital, and if they do need to be in hospital, it'll be for very brief periods of time. Daycare, outreach, treating people at home, all of that stuff will remove the need to have expensive hospital beds and expensive nurses looking after those beds. Well, that was absolute rubbish at the time, and it's absolute rubbish now, but almost every Western country has produced less and less beds to put sick people in per capita. And Canada is certainly no exception to that. And Ontario is the shining star for healthcare control in Canada. We have by far the lowest number of nurses and other healthcare professionals for the population, for the actual percentage of the population, and we have much less beds than anybody else. And that's put us at risk. It's put us at risk of not being able to hospitalise and have trained staff, at least supervising volunteers or drafted people in a situation of a pandemic. We're literally going to be overwhelmed. Most Friday, Saturday nights we're overwhelmed now. My hospital has a brand new emerge built about, I guess, 5 or 10 years ago now. It was designed for 43 patients on a regular basis. We have 40 admitted now down there without a bed, and another 60 to 70 people who are really sick, most of them, waiting to be seen by a doctor. Wait times can be anything between 4 hours and 12 hours, unless you're very, very ill, and then you get seen immediately. And what's going to happen to all of that sort of stuff? Well, what I've seen in my hospital is a lot less people are going to Emerge just to go to Emerge to get their migraine checked out, or they've got lumbar back pain for 3 months and are not happy with their family doctor. They don't seem to be doing that so much right now, and that would continue in a pandemic. Fear of death really does limit people's willingness to expose them to hospital environments. Well, let's think about a minute about the nCoV virus. You know, it kills a fair number of people, but it doesn't kill a large number of people, thank goodness, but it's going to have a systemic effect. Anywhere where you've got 100,000 or more cases, you're going to see a significant increase in demand for ventilator, life support care and hospital beds. No question about that. Now, how many people are infected in Wuhan City? It appears to be enough to absolutely smash their healthcare system to pieces, despite the fact they've built, I think, 3,000 more beds, and they're probably doing a lot of ancillary stuff as well. And by that I mean they've probably cancelled a lot of electric surgeries, they're probably kicking out a lot of people they would normally keep. They're doing a lot of things differently to actually reduce the volume demand for beds, but even so the beds are overwhelmed. They're doing a lot of hallway medicine, they've run out of stretchers, and they're using seats. My hospital's done that before. We've ran out of stretchers and we've had to put people who need a stretcher in our emerge on a seat. Now we routinely now put people on seats. It's very hard to get people off a bed or off a stretcher once they're on it, right? Even if they're not that sick. People aren't that nice. Most people, you go up to them and say, oh, I need your private room to put somebody in who might have the coronavirus. They're going to say, a lot of people are going to say, no, I'm not sharing a room with anybody. Okay, so one of the things right now is that we go through our normal processes with this. So this will also obviously change. And one of the things that will change is that people are used to paramedics wearing lots of gear, they're used to sealed units on stretchers, mega precautions, probably too much precautions to be honest, treating these coronavirus people because we're treating them so we're not at risk, and we're only looking at them coming from China, so we can say it's a Chinese problem, not a Canadian problem. So as the infection develops in the communities, and I expect it to develop in the communities, the question is how much, and nobody knows right now, is that you will see more and more and more people developing signs and symptoms of this infection. And at a certain point in time, elective surgeries will be cancelled. Now as it develops further on, it becomes problematic. We have plans in place to bring in more ventilators. We don't really have plans in place to bring in more nursing staff and more respiratory therapists to deal with those ventilators. And staff who are overworked get sick, so it's a bit of a cycle. And it's not the kind of nursing in 2020 that you can bring in a school teacher and get them to do it after 4 hours training like we did in 1918, 1919. However, what the healthcare system will devolve down into is literally that level of care. People will get a cot, probably an army cot. Ontario has tens of thousands of these ready to go. And they'll get a few volunteers giving them sips of water or maybe cleaning up a little bit of their poo or whatever. They're not going to get chest physio, they're not going to get antibiotics if there's a large number of people, because we will run out of them. And we will ration them for patients who we feel are going to get the most benefit. And Tamiflu is already in that situation. Like I said, I don't know if Tamiflu is ever going to be used for this, and I have to look up why it's not being mentioned. But one of the things is that with Tamiflu, it's given to certain age groups and categories before other people get it. In other words, if we have a limited supply of Tamiflu, I get it because I work in the hospital. Kitty would get it if she didn't because she's my spouse. We want to protect the hospital staff in a flu pandemic, and it was then given to certain categories of people before other people. Healthcare becomes socialist from being autonomy. So for example, the example of the person in the single room in the hospital who's not infectious and we need that bed, they'll be told we're moving you out of this bed. If they complain, they will be probably evicted from the hospital. I'm not kidding. We will charge them a trespass, we will cuff them, and we will throw them on the sidewalk in a major pandemic. Get this, and get this into your heads now. Don't argue with authority in a really bad pandemic. They won't tolerate it for 4 seconds. You don't have any human rights, you're not special. The people making these decisions are highly stressed, highly pressured, and they have to make rapid decisions to protect the good of the general community. The good of the general community is the priority. The individual's wishes we'll try and pay lip service to, but if people are doing things that are actually bad for the general community's health and risk from the pandemic, even if this is not even true, it's just a perception, it won't be tolerated. I did come across one where a cop shot somebody during the Spanish flu because they were wearing a mask, and we've already seen some of, if you've watched my channel, you've seen some of the videos about Mongolia with their drone flights going around annoying people who aren't wearing masks. Obviously some of those people really don't need to wear a mask. They're in the middle of outer Mongolia, there's nobody in that field where the guy's dealing with his truck. But compliance to healthcare directives becomes absolute. It doesn't become something you can complain about. It doesn't become something you can ignore. Okay, so it does get to as bad as Wuhan City in Toronto in the next 2 to 4 to 6 weeks. What the F are we going to do? Well, there's a few things we're going to do. We're going to cancel elective surgeries. We'll try and centralise some hospitals for hemodialysis or chemotherapy and try and put patients there. And then the chemotherapy and the dialysis will be rationed. They'll have to be. But they'll try and keep them separate out. One of the things we'll do early on is we'll designate pandemic floors, we'll move all the patients out as we get discharged, and we'll be discharging people who don't want to go home or aren't ready to go home. We will be discharging them, and we will collect all the patients who are at risk there, and then we'll do that for the ICUs, and we'll carry on and so forth. At a certain point we will start to hallway medicine. We'll start to use our surgical short stay unit, we'll start to use our cardiac short stay unit, probably not for isolation reasons for some of them because of the structural layout, but for other patients that we have to look after, to free up the normal beds that we would normally use for them, specifically for this. Now what happens, what's the capacity? Well, the capacity, I reckon, and it's a very fine thing, is that once we get above a 3 times doubling of our normal ventilated population, which would be in our hospital about 34. So when we have to, we could probably do another 60. Staffing would be major issues, we'd be using the operating rooms to do this, but there are plans in place to do a large-scale pandemic ventilatory response. It's not going to last very long. A lot of stuff's just-in-time plastic. A lot of it comes from Mexico and China. A lot of the ventilatory circuits, we don't take them off and sterilize them anymore. We literally throw them in the garbage or burn them. I think that's a mistake, and I always think that's a single-use mistake. In a case like a pandemic with high need and very low or no replacement, that's a huge error. So that's one of the things they'll probably have to look at, is can we safely re-sterilize single-use plastic tubing for ventilators? And the answer is no, but the answer is we will, because we may have to. So that's one of the things we might be doing. You might be seeing 2-3 patients clustered around where we would normally put 1 patient. What they did in Spanish flu is they put actually bed sheets up to try and stop airdrops getting between the beds. Really good idea, and we may have to do things like that. We have a mobile hospital in Ontario that can take about 100 patients and do ventilation. That will probably be used early on. Now that may well be used at my hospital because that's where it's based, and a lot of the staff come from my hospital. So we might use that there, and we might use it for specific issues. No science behind this, but in Toronto, Canada, I think basically if we're faced with 10 to 20 patients extra a day that require ventilation, and if we're faced with 50 to 100 patients a day that require hospitalization and isolation, the system, and that's day after day after day, I think we're in deep trouble within a day or two. Deep trouble. We're not going to be able to do this. We're going to have to take shortcuts, we're going to have to compromise all across the board. Basic, old-fashioned 1918 nursing will get us through a pandemic. What won't get us through a pandemic is treating every patient with the vast amount of money, personnel and time that we become used to in 2020 for things like Ebola or the nCoV 2019 virus. I don't think so. We're not going to be able to do that, not on scale, not on large scale. Now it doesn't apply in Canada. We have a universal healthcare system. Each hospital actually is a separate private institution that's not for profit, and that's one of the weaknesses of our system. But in a pandemic, the Ministry of Health of each province actually takes command and control and issues directives. Directives are basically law, so the directive is you follow that directive or you're in deep duty. In the US and other places that have private or public and private, what you'll see is the same thing. You'll see your ministry, state or your government health board take command and control. China's actually using the military for a large number of their healthcare districts. What they've done is they've actually put all the hospital people there, many of whom are private, right? They put them all under the command of the local military, and the military nurses and the military doctors are now the commanders of that response in that area. And the military will do things in a tactical way. Again, there will be not just rationing, but there will be exclusion of care to certain individuals based on certain criteria. The criteria actually isn't arbitrary, and it's a smart thing to do, but it's a very much a different thing from what we used to. For example, under the old pandemic plan, which has since been a bit altered, one of my jobs in a massive pandemic is to go around every 24 hours and check who's on the ventilators and to order ventilation removed for certain patients based on certain categories. Why me? Well, because I have clinical background and I'm the manager of the hospital, that's my role, is to keep the operations running. But also because we don't trust the doctors and the nurses to make the decisions about who dies today or should we give them another chance for another day to respond? They won't be able to make the rational choice for that person in front of them. They don't see the other people that could benefit, and it becomes very much socialized. Now, one of the things is that it's a little different. My hospital is terrible about visitation. Like, it's ludicrous the people who are allowed in and what they're allowed to do. Anyway, we've already instituted a policy that NCOV 2019, PUI, persons of interest who are interesting, and presumptive, which is they've got it, but we need Winnipeg to confirm it, or they have it because Winnipeg's confirmed. Those patients are having 0 visitors. We're not allowing visitors in, period. And that's a smart move. In Toronto General in 2003 and SARS, we literally had patients die and we still wouldn't let visitors in. The visitors, I know you love your loved one, you want to be with them, but you are highly suspect at risk, and staff need to be protected from you, because even just sending people home on quarantine in a situation of huge demand is terrible. One of the things people don't think about is where staff are going to sleep in a pandemic, and that's one of the things I certainly will be doing. I coordinate the storm centre response a lot. When we have a snow or ice storm, people want to stay over. It's really important that our nurses and our doctors aren't sleeping on corridors like they are in China. They've got to be looked after. And if they have to be looked after in a pandemic, as much as the sickest patient in the hospital. In other words, what I'm saying here is that in a pandemic, critical importance is the nursing and the doctors, the respiratory therapists, the porters and the cleaners, and the administrative staff who do the filing. They're critically important, and they're not an afterthought, and they are the types of people that just throw themselves into stuff at risk and then die. But one of my jobs is actually, as operations director, is to actually say, no, you're on break now, but I have all this work to do. Don't care, doesn't get done. You're on break for 4 hours. I got to make sure they're rested, got to make sure they're hydrated, and got to make sure that when they lie down, they're at least getting a mattress on a floor and a blanket, right? Again, linen services, we might run out. So again, I would probably institute a plastic bag policy so people would keep their own linens rather than just take their linens and dump them in the hampers, which is normalcy. If we're going to face a pandemic, one of the first things I've got to do is get staff out of the habit of just using stuff singly. You've got to start reusing stuff, but you've got to do it in ways that don't infect you and other people, and that's going to be really tough, and compromises will happen. So for healthcare, it's going to be really tough. For industry, it's going to be very, very tough. For bull terriers, it won't be so bad. One of the things that she needs is she needs to go for walks and stuff, but we've got a big yard and they'll have to make do. It's as simple as that. A lot of us are going to have to make do and be uncomfortable and poorer over the next month to 6 months. And then the economy is going to take off like whoomp, because there'll be so much pent-up demand from the fall. In a lot of ways, this could be an interesting experience. Will the Democratic primaries and the Republican primaries continue beyond next month? I don't know. That might sound a bit alarmist, but back in 2003 I was teaching for college, George Brown, and I was teaching registered practical nurses part-time, and I was working at my current hospital actually, and we were having a meeting about SARS because it had been going on a couple of weeks. There was a few more cases. Now this is an example of old school leadership versus new school leadership. The old lady in charge of the program was smart. She had a strong clinical background, and they were all discussing about when to reschedule, what to redo, what messaging to tell the students. And I just put my hand up and said, this semester's finished. It will not be returning. The situation is so bad in the hospitals, they're going to stop all students, including pre-grad students, and you won't be allowed back into the hospitals probably for a 3 to 4 month period, and what we need to do is plan for that right now. And there was a few questions and asking and blah blah blah, and a couple of the other people worked in other ICUs in different hospitals, and the old lady in charge of the department said, yep, okay, that's the message we're going to give. Semester's suspended, it will resume when we can, until now do this, that and the other. And that's what they did. And they actually put us on retaining, so when the semester did start 6 months later, when they were allowed to restart by the government, George Brown was ready for it, for that program. A lot of the other programs weren't ready for it. They weren't able to comprehend that their normalcy, their ability to teach their students would actually stop and just cease. So a lot of the universities now, they don't teach nurses how to nurse. What they do is they have plastic dolls for them to play with in actual hospital type scenarios. So one of the things is they're planning to put a lot of non-infected patients into universities and colleges and have the students and the faculty look after them. It's actually not a bad option if you can get in there, but other than that, it's going to be an interesting time. A lot of people are going to have to do things very differently, do things they're not used to doing, and get over themselves, and it's going to be for the good of the community. You're already seeing that messaging now in NCOV 2019 from the World Health Organization, appealing to people not to hoard personal protective equipment, not to hoard food. It's for the good of the community. You can't do this, we need this, and our healthcare providers don't have it. You know, that's a reasonable message. It's one of the reasons I prep, so I could hoard without causing shortages, right? And not put myself at risk trying to hoard stuff for my personal and family use going forward. So that's one of the issues here, is like, depending on how bad this quarantining is, I might actually have to start feeding the neighbours. I'm not going to have them round for dinner, but I might actually be producing some foodstuffs and actually giving it to them with clear instructions about wipe the container, use the microwave, wash it out please and return in the bucket outside my house, and then I would treat the bucket as isolated and I would clean it. So I can produce rice dishes and oatmeal dishes on scale for a large number of my neighbours for several months, and in this particular shtf I would do so. I think it's important that we actually listen to the World Health Organization's message about community orientation and deal with it. This whole idea of holding up in your house with your gun and nobody's getting what's mine is fine, but this is only going to be 2 to 3 months. Do you really want to kill people just because you're selfish? Or paranoid? Or insane? Like, I don't think that's reasonable. This is not nuclear war, right? This is a situation where community is first, and it's about time preppers stood up to the plate. I mean, imagine how much prepping is going to be boosting your local town or community if you feed 30 of your neighbours once a week or twice a week during this pandemic, if it gets like Wuhan. Imagine how people are going to go, wow, what a great person. Wow, what a really nice thing to do. Now, yeah, there's OPSEC and all the rest of it, the golden hordes are rushing through your door, killing you. But that's probably unlikely to be this scenario. And I think it's always a good idea, if you can safely do it, to actually be community minded, because without a community we just batter around with our own brains. So that's all for me. If you've got any specific questions about healthcare, let me know in the comments below and I'll endeavour to answer them. We're heading off to 3 nights at work. If there's any updates I'll give you them. The fact is Canada's now got 6 cases. I'm not bothered about that. If we have 600 cases, I'm not really that bothered. If we have 6,000 cases, I'm getting seriously bothered. My real question is, how many are in the community, how many are infectious in the community, and how infectious is it in the community? And the only thing I can do right now is look at China, look at what happened in Wuhan, how it was plateauing quite fine for multiple weeks, and then went, and although cases are reported to drop today, that's great, it might be weakening, might be. I'm not convinced we're not going to see at least several of our cities, if not most of them with airports, experience Wuhan conditions in the next 5 to 6 weeks. That's the concern, and that's something we need to take as a serious possibility. Not as something we can't deal with, so we're not going to imagine it can happen, but as a serious possibility. Alright, so take it easy, and wish me luck at work. We'll shave, but first I have to plough the driveway of snow. And Becky's doing okay with her gimpy paw. Hey baby. But Bear is limping. I do think he has a hairline fracture, so he's not going to be walked today. Toodles! This has been Bad Terrier Production 2020.